Hello everyone, my name is Chao. On behalf of our research team, it is my pleasure to share with you today my presentation. High prevalence of low urinary tract dysfunction in patients with Prader-Willi Syndrome. I have nothing to disclose. Prader-Willi Syndrome is a genetic developmental disorder. Prevalence of Prader-Willi syndrome rated from 1 in 8,000 to 1 in 45,000. Lack of expression or disappear of paternal chromosome 15 is the main cause. Usually, patients with Prader-Willi syndrome have neonatal hypotonia, hypogonadism, hyperphagia with marked obesity, and cognitive and behavior problems. Elimination disorders such as urinary incontinence, fecal incontinence have been described in the previous literature. However, few studies mention the low urinary tract dysfunction in these patients. From one study, 13.6% patients had nocturnal enuresis and 3.8% patients had daytime urinary incontinence. 20.7% adult patients had at least one elimination disorder from another study. Both studies used questionnaire to evaluate whether a patient had urinary incontinence. Therefore, our study aims to use non-invasive objective exams to evaluate the prevalence of low urinary tract dysfunction in patients with Prader-Willi syndrome. This is a retrospective study. We included patients diagnosed with Prader-Willi syndrome in our hospital. DVSS score, uroflowmetry, and post-voiding volume was measured. Definitions of LUTD included the following criteria: peak flow rate lower than 15 ml per second, abnormal uroflow patterns, and elevated PVR. Patients who fulfilled any one of the following criteria will be defined as LUTD. Between 2016 to 2017, 37 patients were recruited from our outpatient department. 10 of the 37 patients have self-reported LUTs, including urinary incontinence from DVSS score. Among them, 4 had daytime urinary incontinence. 3 had daytime urinary incontinence and nocturnal enuresis. 1 had only nocturnal enuresis. Other 2 patients had LUTs without incontinence. Mean age of our study group was 17 years old. Male to female ratio was 15 to 22. Mean BMI of the patients was 28.5. Patient with Prader-Willi syndrome had intellectual disability in general. 8 patients had diabetes mellitus. The 37 patients were classified into 2 subgroups based on the presentation of LUTs. Although not statistically significant, Prader-Willi syndrome patients with LUTs had higher BMI, lower IQ, and higher percentage of diabetes than those without LUTs. Uroflowmetry was performed in 36 patients. 2 patients had voided volume less than 50 ml and refused to repeat uroflowmetry. Thus, they were excluded from the following analysis. 12 of the 34 patients had peak flow rate lower than 15 ml per second and abnormal uroflowmetry patterns. 10 of the 20 patients had elevated PVR. Peak flow rate and bladder capacity were statistically lower in symptomatic group than non-symptomatic group. From our study, cases with LUTs have lower peak flow rate and smaller bladder capacity. As for the analysis of uroflowmetry pattern, bell-shaped patterns were observed in 65% of the patients. Of the 8 Prader-Willi syndrome patients with LUTs, 6 had abnormal flow pattern. Rate of the non-bell-shaped pattern was statistically higher in symptomatic group than non-symptomatic group. In conclusion, half of the Prader-Willi syndrome patients had at least one abnormality from the two non-invasive exams. Therefore, we suggest that non-invasive studies such as uroflowmetry and PVR is recommended to patients with Prader-Willi syndrome. Thank you for your attention.